All right, good morning. My name is Molly Shields. I'm a fourth-year medical student from USIS. And today I'll be presenting on the evaluation of a military global health engagement mission for critical wartime surgical specialty readiness. And this is done in conjunction with Walter Reed and USU. So this disclaimer, the views expressed in this article are those of the authors and do not necessarily reflect the official policy or position of the Department of the Navy, Department of the Defense, or the United States government. So as we just heard from our last presentation, surgical volume at military treatment facilities, or MTFs, has been gradually decreasing roughly for the past two decades, as detailed by the following papers here. Additionally, an increasing proportion of cases have been referred out into the community, which has been fueling concerns for military surgeons about their case volume and their readiness for their surgical personnel. Additionally, the recent cessation of direct combat operations in the Middle East, fewer U.S. surgical surgeons are going over to those places to provide combat casualty care, while still being expected to provide that type of care when called upon in those few instances. So as a result, military surgeons face the dilemma of maintaining their skills while faced with decreased surgical volume at MTFs as well as these surgical missions. To examine this issue, the Joint Knowledge, Skills, and Abilities, also known as the KSA Clinical Readiness Program, was developed to quantify surgical volume and correlate routine cases with skills needed for trauma surgery. The KSA Clinical Readiness Program links readiness to a surgeon's case log using a metric known as the KSA score. The military health system uses a KSA threshold of roughly 14,000 points per year as a measure of a general surgeon's deployment readiness. So how is this score measured? So each current procedural terminology or CPT code associated with a surgeon's NPI generates a numerical value. For general surgery, the KSA scores are adjusted to account for diversity of procedures through a fractional adjustment. So this is calculated by the clinician's procedural diversity divided by the MTF's procedural diversity to then adjust for the points. And there's a cap on low acuity procedures if it makes up 50% of total case volume, so that there's a maximum of 7,000 KSA points that can contribute to one surgeon's general readiness score. And in order to capture this diversity over time, the KSA score is derived over a 12-month period, and therefore any time shorter than that is only a raw score and can't be adjusted for diversity. And so in the figure here, I know it's a little bit small, but you can kind of see just the different procedures that a surgeon can perform and the KSA points that are given to that type of procedure. So the objective of our study was to assess the extent to which military medical missions contribute to the readiness of critical wartime specialties using the KSA as a metric. So while surgical volume for the comfort missions has been extensively published, there is currently no literature that utilizes KSA data from surgical missions and performs a direct comparison to the MTF data in order to evaluate the utility of these missions in achieving surgical readiness. And lastly, we're hoping to offer solutions to this decreasing surgical volume experienced by military surgeons. So this was a retrospective analysis that was conducted using the surgical case logs from the comfort missions of 2018 and 2019. There were 3 Navy general surgeons aboard the mission, as well as 1 orthopedic surgeon. And the KSA scores from this surgeon from the 2019 mission were calculated by the Joint KSA Management Program Support Team. And the values from the missions were compared against each surgeon's practice at their respective MTFs during the remaining 6 months of that calendar year. And so the results that I'll discuss kind of go in 3 different buckets. So this first one here, we'll be looking at the general surgery practice aboard the Comfort produced lower KSA scores compared to the surgeon's respective MTF practice. So as you can see here, the first column is the raw score without being adjusted for the diversity. And then the second column is the final KSA score. And you can see how the MTF in that last column is substantially higher than the final KSA score. So the total raw KSA score calculation for the comfort missions in 2018 and 2019 demonstrated a decrease in total general surgery productivity when compared to similar missions back in 2009 and 2015. And these general trends are consistent with decreasing general surgery cases that have been reported previously. So the second set of results that we will look at here. Okay, so I just skipped a slide. Oh, this is it, yeah. So the second, we'll be looking at diversity. And so 568 procedures were performed, and 3 of the most common cases were cholecystectomy, inguinal hernia, and an inguinal hernia. And all of those make up 90% of cases, with a laparoscopic cholecystectomy being the single most performed procedure over 1/3 of the cases. And then you can see how the diversity of cases and the complexity of cases is clearly not quite what you would want it from the deployed setting. The last results that we'll look at is from the orthopedic perspective. The orthopedic surgeon aboard the Comfort had a total KSA score of 44,000 during the 2019 year, but during the 6-month mission, only 5,364 points were come from the actual ship mission, which was less than 12% of the annual score. And here you can see the diversity of the orthopedic cases, with the hand procedure being the most common, about 1/5 of overall cases, so not quite the trauma procedures from an orthopedic perspective either. So in conclusion, overall, the analysis of the operative data from 2018 and 2019 Comfort missions suggests that ship-based missions are ineffective in preparing surgeons for emergent procedures that are common in the deployed setting, such as open procedures, vascular or thoracic procedures. There's minimal diversity in these procedures, as we discussed, of over 90% of them being hernia repairs or laparoscopic cholecystectomies. And there's a limited benefit for these missions to bolster surgical readiness from both the diversity perspective as well as case volume. However, in summary, this is not a reflection of GHE in terms of its usefulness. It just comes from a surgical diversity usefulness and volume load. We can see that the numbers aren't quite there, but GHE will always be an important element of the military. I think that using the KSA program will help us to put our efforts toward impactful missions that improve readiness from a surgical volume case load perspective. And so this may involve limiting ship-based missions for the purpose of trying to maintain surgical readiness from a volume perspective. Some solutions that have been offered in the past, as well as we'll offer today, is using the KSA dashboard for input from off-duty deployment and non-military facilities to track readiness more accurately. So this includes when surgeons moonlight or go to civilian programs to get more complexity, more volume. That's not currently factored into their readiness, and I think incorporating that into the overall score will help us recalibrate the overall readiness of surgeons in our military. And finally, potentially using more short-term surgical missions that maybe have a more intense surgical load could help surgeons get their volume rather than these longer 6-month missions that may have limited diversity and lower case volumes. That's it. Thank you.